Hi, I'm Professor Becky Malby. We have been running a program of work on how do you ensure that all our services in the NHS are fair and equally accessible to all. And as we've been doing this work, we have discovered some really interesting things that we think will help primary care. And that's what I'm going to share with you today. So let me just put this on full screen for you. Now, when we've been working with primary care, what we found is that most primary care systems we work with, and particularly general practices, are busy reacting to demand. So what you do is wait to see what comes through the front door, react to it, put on appointments, etc., because somehow the world's focused on just volume of appointments, not quality, not length, not meeting need. Let's see what happens if that's what we do. So what we found is that reactive care is really unequal. So in this frantic world of general practice, on the whole, you wait for people to come to you. And on the whole, those that get more. But also, GP appointments are absolutely skewed in our population to a small proportion of people. So let's have a look. You can see in the left-hand column, these are the number of people on your list. And on the whole, you rely on about 40% of those not turning up in general practice at all. And then you've got a percentage of a population that are infrequent attenders, and then you've got a percentage that are frequent attenders. So let's have a look at the ones that are frequent attenders. That's the right-hand column there. And what you can see there is that of those people who turn up frequently, 5 to 10% of your population, they take up about half of GP appointments. And if they're going to take up half their GP appointments, that's predictable. And if you've got predictable care, you can plan for it and design your general practice system to meet their needs. Let's have a look a little bit further around this. Here's another practice. This is a practice not far from me, here up in West Yorkshire. And here's a slightly different number, but it's within the same vein. So you've got probably 9% of GP appointments and the 2 years before. You could have pre-booked here. 9% of next GP appointments for this practice, you can just put in. Now, if you do that for people who turn up frequently, the first thing you do is you reduce the demand on your reception first thing in the morning. So with this Bradford practice, if they took their long-term frequent attenders, they know they're going to come, they know who they need to see, and they pre-booked them, maybe for longer appointments, maybe with the same GP or nurse or therapist. Actually, they might meet those persons' needs, but also reduce the footfall of calls first thing in the morning. Now, there are two types of people who turn up frequently, and this is fabulous data from Tony Hufflet, who I work with. Now, you can see here on the left-hand side, these are the short-term episodic high attenders. So these folks right up here, you've got our 2019. So they take up GP appointments, and then at the end of the year, they sort of fall away. We've managed to solve their problems. And then you look at 2020, another group move in, 2021, another group move in. I sort of in this practice between 350 and 450 patients. So even your people who turn up frequently, you've got some people who come, they have problems, maybe it's social determinants as much as it is health problems, and over the course of a year, it gets solved. And then you've got the people who are persistent, long-term, high attenders at the general practice. So two different cohorts to be thinking about now. Now, when you have a look, this is work that my colleague Nick Downham did in a practice. And again, we've repeated this in many. If you look on the left-hand column, you'll see here we've got medical complexity and acuity. And these are things that GPs have taken these patients and they've classified them. So on the left-hand side is complexity and the top is social context. And you can see we've got groups A, B, and C. So our folks who are really in turbulent life conditions and who've got really high medical complexity, they don't see many of those. And you see a few people in general practice who've got medium complexity, low acuity and low acuity, who've really turbulent times. They're probably well known to social care and the voluntary sector. And then in the left on the green, you can see you've got a fairly significant percentage. You've got medium acuity in terms of their health needs, and they're pretty stable in terms of their social context. And then you've got this group B, low or medium complexity. They're really under pressure. And actually, if they've got low acuity and there are huge social determinants that are the problem, 20% nearly of this general practice appointments, probably not an awful lot a GP can do. And of course, that's why we've invented social prescribing. But that has to be a transient object. Social prescribing can't be a long-term answer because those folks are probably best not seen in general practice at all. Or maybe they're people who you might see in the future and you just want to keep an eye on. But on the whole, we need to be working with our community of voluntary sectors and social care sectors, making our own luck to say, actually, this is not clinical stuff. There's not a great deal we can do in general practice for folks like this, beyond offering moral support and some guidance. So let's have a look at our proactive future. We think possibly 20% of future GP appointments are already booked on the whole with our long-term. What's the best way of handling those people? Let's think about continuity. So typically, a person who attends frequently based on sort of medium across 12 practices in this case, so they're going to have 15 to 20 GP appointments. That is going to cost the practice thousands of pounds. You're probably getting around £90 a year for this person. That slide deck I showed you earlier on with the people who don't turn up at all, of course, are subsidizing those that turn up a lot. But actually, if they're costing so much and they're coming all the time, we're probably not meeting their needs. Now, for some people with chronic disease, as you know, they have a dip. So for some people, we know that we steady them along, they have a dip, we steady them along, they have a dip. So of course, you're going to have periods of time where people turn up frequently. But if it's year on year on year, we've probably got an issue here that we need to handle. And what's interesting about this is that we're finding across the practices that we look at, they're often seeing 8 to 10 different GPs, none for more than a third of those appointments. So there's very little continuity. There's multiple. If we look at the case notes, we ask our practices, can you do a deep dive on a couple of these? And you'll see multiple touch points, multiple tests, sometimes not followed through, not really looped through in terms of diagnosis. So let's have a think about, could we provide more continuity? And what we know is that where we provide more continuity for people like this, we find that their need drops, i.e. they ask for less appointments, but actually their health outcomes improve too. And the other thing that we know is that where we are able to offer continuity and longer appointments for people with complex illnesses, we know general practice morale improves, both of GPs and their colleagues. It boosts morale, it helps people feel more motivated and more satisfied with the work they do. What's interesting, of course, is you think that the people who turn up frequently are the ones that get more continuity, but they're not. Actually, this is not untypical of a practice data that we run. And what we find is that actually people who turn up like every couple of months are more likely to see the same GP or clinician, and people are turning up twice a week. Maybe that's because they demand it. Maybe it's because it's easier. Maybe it's because the receptionists recognize it. But there is something about a pattern here around continuity, that our frequent attenders, people whose needs are not being fully met potentially, we ought to be offering something better. Here's another example. Now, the green blob right there in the middle that says 50% or 67%, those people, 1, 2, 3 in this list, we're seeing somebody reasonably frequently. If you look at those dots, they are all different people, different clinicians or advanced practitioners or colleagues. And these patients are seeing, as you can see, multiple people. So how interesting. And interesting with this, these aren't people with long-term conditions. These are people who are just turning up frequently. So what on earth's going on? I'm going to come back to in a minute about who are these people that turn up frequently. Bit of a thought experiment here from us, which is we think it's possible, £10,000 practice, 700 turning up frequently, very few, 200 odd with 230 low continuity. What if you screened and provided continuity to 200 of those patients? What if we managed to, we think you could probably release about 1,500 GP appointments. It's huge here. So not only is it better for patients, not only does it improve morale, not only does it improve health outcomes, maybe meets needs better, it also liberates time. So whilst the appointments may be longer, overall, if they're coming that often, you're going to actually save quite a lot of time and potentially save quite a lot of money. So it's a bit of a win-win here, isn't it? Why don't we screen these? How come we don't know? So that reaction, we're too busy, we have to just open the door and see who comes. actually is costing everybody a lot, both in terms of clinical outcomes, but also money and motivation. So what's the other thing that's interesting is that it's not just people with comorbidities who turn up frequently. We find there's all sorts of other people that turn up frequently too. Let's have another look. So this is a segment of a population that's practicing Hastings. So we had a look at the people who are turning up pretty frequently there. And what we found is they're sort of top attenders. And we found we've got the celebrity patients, that's number one. So people we know really, really well. We've got this, look at this, 91 patients with no long-term condition taking up 3,856 appointments, some with mental health only. Here's a group of younger people, 35 years old or younger. There are 44 taking up nearly 2,000 appointments. The expected older age over 70s, that's the people we expect to see, don't we? Most of our work tends to be geared towards those people. Mental health and other long-term conditions, age 35 and upwards. Again, this is middle-aged people, not just old people. So interesting, when you look at this, you think, actually, people's gut feeling about people who turn up frequently is mental health and old people. So comorbidities in old people. And actually what we're seeing is it's not quite the case. So if we're not careful, we could tailor our response to people who turn up frequently based on our assumptions. And that was one of the propositions in our universal healthcare video that's on our front page. Based on our assumptions, we might end up with a multidisciplinary team pointing at the wrong problem, or our R's roles pointing at the wrong problem. So you need to design multidisciplinary teams. Maybe you're integrated neighborhood teams, or maybe you're working in a PCN where you're collaborating around your R's roles. You need to design those roles around known need, not assumptions about need. And we think, whilst you might have lots of access to population health data, that tends to be clinical data. So you'll know an awful lot about diabetes prevalence or screening prevalence. We think you should look at your people who turn up frequently, your regular and frequent attenders. So of your frequent attenders, those are going to sort of turn up for the year. Some of the R's roles would really help them, move them through the system, help them move out into being less frequent. And our long-term frequent attenders are people who are persistently attending year on year, who may have complex social determinant needs as well as clinical needs, and where we might need a different sort of multidisciplinary team. So if you designed your integrated neighborhood team around frail elderly, and this is your population, or maybe in Bradford, where it's got the youngest city in the country, that isn't going to meet all those needs. And what you've got to do is say, what are the needs? And then design the teams around them and the scale of those teams. So for this practice, they found this cohort of younger people, 35 or younger, those 44, and they began to work with their social prescribers and their partners to say, what would be the solution for those people? Because clearly we're not meeting their needs with limited GP appointments. In fact, we hadn't even recognized they were turning up frequently. So it feels like you've got to really proactively manage your frequent attenders in a win-win. It's a win-win situation. A win for the practice, a win for patients, a win for the clinicians, and a win for the rest of the patient list because it increases access. I think it's a really important finding and not difficult to do. I can provide some information on our website about how do you scrutinize the data, but it's all there for you, really not difficult. If you've got a business intelligence role in your PCN, a data role in your PCN, get them to come in and just have a look at who's turning up frequently in your practices. And I think it matters around this, because if you think about who needs to help us in general practice deliver the best care, then if we've got people who are turning up frequently or turning up in our practice who are struggling with life, we've got real issues around poverty and housing. You need an awful lot of help from the third sector, from your community volunteers. You've got to reach out and say, can you help us with that? And your social prescribers should be beginning to make those relationships in your communities do that. Then you might have people who need a bit of help with their context just in terms of managing. Maybe a social prescriber who provides health coaching is a health and wellbeing worker, is a good life skills support to those people. Then you've got people with multiple conditions, risk of becoming unstable. You want some continuity with a GP, or a GP and one or two clinicians, or led by another clinician. It could be a team, but you still need some continuity. Then you're getting into this complex care where you might need a nurse or another clinician really leading the work, or you might need multiple agencies. And then you might need your high intensity users. And these acuity tips are the things that should determine the team and also the size of the population, i.e. the spread of that team, i.e. scale. So that's what we think you need to really pay attention to. And just a few words of warning around appointment data. So we know that there is an awful lot of attention paid to how many appointments you're offering. But we know there's real problems with appointment data. And actually, there's lots of GP time that's absolutely disappeared into unknown amounts of emailing and voice messages. And anyway, what's an appointment? And just we had a look at the GPAD data, and you'll find this on my blog at Becky Malby Learning Journeys on WordPress. You'll find this here. But we correlated patient satisfaction with appointments to the practice name. We had a look at patient satisfaction appointments. How much is that correlated to numbers of appointments? And we found it's exactly the same as patient satisfaction with appointments is correlated to the number of letters in the practice name, i.e. there is no correlation between patient satisfaction with appointments and number of appointments offers, because that's not what it's about. Actually, when you ask patients about access and they say, I don't get appointments when I want them, I struggle to get through, often what they're saying underneath that is, my needs aren't being met. And if you proactively manage those people that are turning up frequently, then they know when their appointments are coming. It liberates space for appointments. But if you look at patient satisfaction data, i.e. you delve into that, and it's a really good indication of how good a practice is. If you look at that, you'll find practices are operating a differentiated model with a range of appointments to meet their patients' needs, longer, shorter, and even better in some places, beginning to move into that proactive process. So where patients' needs are being met, they're going to be more satisfied with your general practice. So you could be offering loads and loads of appointments and getting really poor practice satisfaction data, and that's probably because you're not meeting their needs. I hope this is really helpful. Can only encourage you, please delve into the people that are turning out frequently and see whether you can proactively meet their needs. Thanks very much.